to study longevity in humans takes a long time, right? We live a long time. We're relying on tests like maybe like the true age test and these biologic age markers, but we don't actually even know if they're very accurate for these things. Like I said, you could have, your biologic age could look great. Somebody says, oh my gosh, you're 25. And then if you look at the immune age, it's 85. The problem is we don't quite know how to weigh these different things when we're doing these biologic age tests for methylation markers and things like that. We hear all the time, right, from Brian Johnson and all these people, oh, my biologic age is 35, and it's like, that honestly doesn't mean much because, again, you could have one organ that's 18 and one organ that's 80, and which of those organs is more important to you? So when they average these things out, there are a few labs that are doing that a little bit better, like Generations Lab is looking more organ-specific at things, so you can kind of say, okay, this is what's going to kill me. But I still think we're a long way from being able to rely on those tests as saying, okay, this drug really has the right impact.
I would love to talk about how the immune system ages with us. I think many of us, because it's not tangible, we can't touch it, we can't see it per se. What is changing with our immune system as we are navigating perimenopause and menopause? Because it's quite significant, and I don't see enough focus for most people that are talking about the perimenopause and menopause transition. Not enough of us are talking about how these changes in our immune system really regulate how we interact with the world and how healthy or unhealthy we are.
Yeah, let's first talk about how critical our immune system is to longevity. In fact, Stanford actually started this study looking at what system was really the most critically important. We have all these studies now that are looking at, is it gut? Is it, what is if you were to pick one system that was kind of in charge of aging, it would be our immune system. And when our immune system starts to fail, everything else goes awry, right? If our immune system is really hardy, I mean, when you've got your best immune system at puberty. So, our immune system's robust and you don't see a lot of bad things happening at puberty, right? People are pretty much in a pretty good state of health, maybe emotionally unsound, but, in pretty good state of health. They don't get sick very often. You don't see them dying of viruses. You don't see them getting cancer very often. As we get older, that gets worse and worse. And it's really because our immune surveillance becomes dysfunctional. We don't recognize self anymore. We don't recognize cancer cells anymore. So Stanford actually came up with a test that I've been following for a long time called the age test, which instead of people doing these robust, okay, what is my biologic age? You could actually just look at immune age as probably the primary marker. And they came up with about 6 different things to look at that really predicted immune age. And I think that's why when we look at, okay, what's affecting our immune system as we age, what happens? Well, there's lots to that. But if we talk about, for instance, as we get older, actually even really, I say older, but really our hormones start to get dysfunctional even in our 30s, right? We start to see imbalances of estrogen and progesterone. One of my sons has a girlfriend who's in her 30s. He's in his 20s, but his girlfriend's in her 30s. And, I was talking to her about things. And I said, you're already, and she's like 36, 37, but she's already obviously showing some signs of progesterone, estrogen imbalance. So I think we forget that this starts much earlier than the 50-year-old who oftentimes presents to us feeling, fat and tired and everything. It really starts in our 30s. We start to see this decline because for instance, our progesterone starts to decline really sometimes in late 20s. As does our testosterone. So when we look at the influence of things like that on immune health, really our T cell function, our lymphocyte function, our natural killer cells, which are the cells that go off and fight cancer, it's absolutely critical. For instance, progesterone is a really clear immune modulator. We know that it affects the immune system to sort of stabilize it, to keep it from kind of going haywire and attacking self. So we know that progesterone is really critical there, as is estrogen. Probably more critical is that balance between the two. And as we see, we hit this point, where that balance becomes very skewed to estrogen. So it's not necessarily always low estrogen that's the problem, right? It's that imbalance between estrogen and progesterone. So as progesterone's dropping, estrogen oftentimes stays high for a long time. Then we start to see this immune imbalance. And then I think the forgotten hormone in all this is testosterone. Because when you look, women have much more autoimmunity than men, right? You see much more autoimmune disease, thyroid disease, rheumatoid arthritis you see in women over men. And largely that's because testosterone has a very protective effect for the immune system as well. And so men will start developing autoimmunity much later as their testosterone levels drop. Women start developing it very young. Our testosterone levels are really in our 20s peaking, and then they start to drop. So, and if you do things like birth control pills, which completely deplete testosterone, then you're really in trouble. You give you this very high doses of estrogen, no progesterone in birth control pills, just progestins, and you've suppressed testosterone because it increases binding of testosterone. So we get these women who are really starting to see dysfunctions with their immune systems even at a very young age. So you can imagine if that's going on now for 10, 20, 30 years, what happens? We're going to see people with thyroid. You see, the autoimmune thyroiditis, right? We see a lot more people with eczema. We see a lot more cancers starting to develop. So I think that we really forget that plan. I'm so glad you brought it up because we really forget, number one, that the immune system is the top of the pyramid, and that, well, I'll say maybe the bottom of the pyramid. It's the base of everything, and that the hormones are a critical player there.
Yeah, you bring up so many good points. And something that I think about a lot is certainly my generation. I'm in my early 50s. My generation, almost every single female friend I had was put on oral contraceptives
Yeah,
early.
yeah.
So we had our teens,
At 12 and
20s.
13 sometimes, right?
Yep. So think about like, over time, how much our bodies were not being sensitized to estradiol, testosterone, progesterone, and thinking about the net impact. I don't have any girlfriends who do not have multiple autoimmune conditions, not one. And I
Yeah. It's
wonder,
astounding, right?
yeah, I mean, it just makes me wonder what are the long term effects. And obviously, I always say this in the podcast, like women need reliable contraception,
Right.
full stop. But certainly our like my generation just was not aware of
No,
like the
no,
effects.
I'm a little generation ahead of you, but yeah, we were, birth control pills were easy. They made sense. Nobody told you there was any risks to them. Everybody took birth control pills, right? And then we started using them to treat acne, and we started using them to treat mood disorders, and we started throwing everybody on them. And I'd like to say it's gotten better, but I think it's maybe better. There's a little bit more awareness, still not a lot. If you still look, it's huge, a huge amount of the population who's put on birth control pills, right?
Well, I
And
mean, look at all the middle-aged women that are thinking
right, we're
about
still
hormone.
taking them, right? I have women
Yeah,
who literally are
exactly.
still, I see in their 50s, right, still taking birth control pills. They've been on them literally since they were 20, and they're like, well, my doctor said just keep taking them because they're giving me the hormones I need now. I'm like, no, they're not actually. They're giving you a whole bunch of estrogen and nothing else.
Yeah. Well, and it's interesting how sometimes patients will come into our practice and they're like, yes, my provider put me on HRT. And I'm like, great, what are you taking? And they list it out. And I'm like, that's not HRT. HRT and oral contraceptives are different
Very,
dosings,
very
different
different, right?
medications, different hormones. And so, if anyone's listening, just to provide clarity, oral contraceptives are not hormone replacement therapy or hormone
Right.
replenishment therapy or whatever terminology we're using right now. I think that's an important distinction to make
It
because I
is
think
important.
there are people who
Who really do
truly,
think that. Right.
yes, because they don't know any better. When we're thinking about factors, items that impact supporting our immune system as we're getting older. Obviously, the hormone piece is certainly important. What are some of the medications that you're seeing being utilized to buffer the immune system? Can be inclusive of peptides. This can be, rapamycin, low dose naltrexone, a lot of these drugs that we're seeing that are being discussed and talked about that maybe not necessarily every prescriber is utilizing, but we're seeing good data on and good results with patients.
Right. So I think that when you look at low dose naltrexone, I love low dose naltrexone. For those of you guys who don't know, naltrexone at a high dose is an opioid antagonist. It blocks opioid receptors. But we're talking about micro dosing it. We're not using it in 40 milligram doses. We're using it in like 1 to 5 milligram kind of doses. And what it does then is, as when you sort of like when you tickle the opioid receptors, you actually modulate the immune system. And the word modulate's key here because it's not going to spike up the immune system or suppress the immune system. It's going to stabilize the immune system. And that's why it's so incredibly useful for people with emerging autoimmunity type pictures. It's been well documented now with ulcerative colitis, Crohn's, some of the GI issues, right? I put most of my autoimmune thyroid people on low dose naltrexone with significant benefits, and it's really well tolerated. When you first start taking it, you have to kind of start slow because it can give you sort of nightmares, keep you awake a little bit. But if over time people adapt to it really well, and it's probably going to have anti-cancer effects. It's got that long-term immunomodulation is going to be good for a whole bunch of things. I think the only risk of this drug is sometimes if you're on it and you have a surgery that now you need opioids, you might have to stop the drug or take more of the opioid to counteract it. And so sometimes the docs will be like, "Oh my God, you're taking all this medication. Why?" And you have to either stop the low-dose naltrexone, which I always hate to do, or tell the doc, "Listen, it's because I'm on a drug that's blocking these. I need more." So I think that's really the only downside of those drugs. Otherwise, they're hugely beneficial. When you look at drugs like rapamycin, rapamycin, we don't have a whole lot of clear data on. We know that it's really good for some things. We know that it's great for ovarian aging, right? At least in an animal model, it appears to be really great for ovarian aging. In most animal models, it appears to delay the onset of menopause, which is nice. So I actually will use it a lot in my young females who are 35, 33, and haven't met a guy yet, and and they know they want to have kids. I'll actually put them on rapamycin to preserve fertility. Now, do we know for sure it's going to work in humans? No, we're actually doing some research with a group right now trying to figure out if that's true, but hopefully it will. And I think the downsides are pretty minimal. As far as an immune modulating agent, again, remember rapamycin is a cancer drug in high doses, so it's designed to kill cells in high doses. So what we use is a microdose used once a week with the hope that what we're doing is getting rid of damaged cells and allowing good, healthy new cells to form. So basically, I sort of look at it like cleaning house, right? You accumulate all this trash all week, you throw out the trash. You accumulate trash, you throw out the trash. So it's basically inducing autophagy of a lot of the damage. And you can see reflection of that in some of the labs we can look at. For instance, you can look at something called a mean cell volume on the labs, which is the size of the cells. And if that gets bigger and bigger and bigger, probably there's more senescent bad cells, and we can see that get smaller on rapamycin. So I do think there's some key points there. In so doing, and basically in blocking this mammalian target of rapamycin or mTOR, we are modulating the immune system as well. Now, the problem is in some people, it's very hard to figure out the dose that modulates without suppressing. Because in a higher dose, this drug is immunosuppressant. And I have had people who, even at the dose we typically use, which might be something like 6 milligrams a week, will start getting cold sores or start getting sick more often or start getting a drop in their lymphocyte count. So the hard thing about rapamycin is finding the right dose for people. And we don't really have a great, everybody's like, well, 6 milligrams a week. For some people, that's too much. Some people need 3 milligrams a week. So it can be a little bit of a tricky drug to find the sweet spot of, right? I think it has, I think right now it has huge promise. I think we still don't quite know, are we giving enough of it? Are we giving too little of it? So I think that's something it's only going to be time. This Pearl study that's going to be published should start giving us more information. We're doing the studies. It just takes a long time to study aging in humans. You can study it in mice. You can study it in dogs. It's very hard to study in humans.
Yeah. And I
So
think perhaps for listeners, not really appreciating that sometimes we have animal model research and we extrapolate that into human research. Human research is a little more complicated, a little more complex than rodents who have a different lifespan, different gestational, timing frame.
right.
And so I find all this absolutely fascinating because for me, I think that these are certainly never things we learned in medical training. It's been this evolution of kind of a functional, personalized, integrative medicine approach that I find really fascinating. As you were astutely saying, each patient may actually need a different dose, but it's figuring out what the right
What that
dose
dose
is
is,
for each
right.
individual.
And again, we don't, to study longevity in humans takes a long time, right? We live a long time. So you're talking about looking at, people over 70 years. And so it's going to be hard to figure out. And so, that's what we're relying on tests like maybe like the true age test, some of these biologic age markers, but we don't actually even know if they're very accurate for these things. Like I said, you could have your biologic age could look great. Somebody says, oh my gosh, you're 25. And then if you look at the immune age, it's 85. Well, if I weigh immune age much more than your kidney age or your, cardiac age, then you're not going to do so well, right? And so that's a problem is we don't quite know how to weigh these different things when we're doing these biologic age tests for methylation markers and things like that. So still a lot, people are putting a lot, we hear all the time, right, from Brian Johnson and all these people, oh, my biologic age is 35, and it's like, that honestly doesn't mean much because again, you could have one organ that's 18 and one organ that's 80, and which of those organs is more important to you. So when they average these things out, there are a few labs that are doing that a little bit better. Like Generations Lab is looking more organ specific at things, so you can kind of say, okay, this is what's going to kill me, you know. But I still think we're a long way from being able to rely on those tests as saying, okay, this drug really has the right impact. So I think that, like you mentioned, we're relying a lot on animal data, which may or may not mount to human studies. I think the main thing to think about, because I know that scares people, is that most of these things, like rapamycin, has been tested at very high doses, right? It's safe. So we do have safety profiles for a lot of these things. We're maybe using like naltrexone. We know it's safe. So we're using drugs that at least has lots of times a safety profile that's been pretty well documented, and using them in a purpose that's just different from what they were, designed for. So I think that is the upside, and why you can adopt these things. Because sometimes if you're not an early adopter, well, maybe you've lost, the footing on it. Maybe at this point you're not going to get any value because you started it too late. So I think you have to be a little bit cautiously early adoptive of things, as long as things are safe. And I think that's where it does help a lot to work with a provider who can look at labs and say, this drug is not doing the right thing for you. I can see changes in your lymphocyte profile that are the wrong direction, or liver. There's lots of little subtle things we can look at in labs that say this is not the right drug for you. If we look at a drug that I think is probably you're going to start seeing, well, we've already seen it, but that gets kind of forgotten in the immune world. It's the GLP-1 agonists. So GLP-1s, I know, have gotten a really bad rap, right? Now they're being sued for blindness. There's all the people who end up in the hospital with constipation. That's because when these drugs are used inappropriately, which unfortunately is happening very widespread, and used for rapid weight loss, then problems are going to happen. But a micro dose of GLP-1s, when you're using them at maybe a quarter of the weight loss dose, where you have no side effects, no symptoms, you feel completely normal, your appetite is still fine, they have really good immune modulating properties. There are GLP-1 receptors on immune cells, so it actually stimulates normal immune function. So we actually get better T cell activity. We think they're going to have some good anti-cancer properties as well. In fact, that's always been shown. We've documented them for neurodegeneration. We've documented them for osteoarthritis. So it's actually, in my mind, I'm actually using the GLP-1s at a low dose, even a little bit more than I use rapamycin now, because I do feel like they have such a widespread benefit beyond longevity.
Well, I think it's so interesting because when, they've been around for a while, whether people acknowledge this or not. I
Right,
think my mom
exactly.
was on Byetta like 10 years ago.
Yeah, I know. People forget that these drugs are actually old. They're just
Yes.
redesigned them old.
Yes. And so I really think that there are individuals, I don't want to sound pejorative, but there are people out there that are in these like weight loss mills that are putting everyone on a protocol. They're not bio individualizing the dosing, they're not monitoring,
Right.
and not every person needs a full dose. And so what
No.
I've come to find, and I'm taking it personally just for anti-inflammatory immune support.
Yeah,
And
me
I was
too.
saying,
And you and
and
I are
I'm
both thin, right? We don't want the weight loss. We want the other
right.
benefits of it.
Right. And so even my husband is now taking it, and he was saying for him, he's on tirzepatide. He said it just quiets the brain just enough. And not that he didn't need to lose weight either, but it's fascinating to
It
me
is
when I
fascinating. Like, right. It's weird, right? Like some of the things, I won't say I had a coffee addiction, but I liked drinking coffee. But I must have had a little addiction, because now I like, I can take it or leave it. So it does some weird things to your brain on things that, that maybe you have a little bit of a propensity to be using in a purpose that's beyond, just enjoying them.
yeah.
So they are very interesting drugs. Or if you would have stuck a plate of French fries in front of me, I would probably eat French fries. But you just don't have a desire to, right? And again, I'm taking a dose where I don't, I need to eat, I need protein, so I have to take a very low dose, but I want the neuroprotective effects. My mom had dementia. I don't want dementia. I have an autoimmune disease, and so I need the immune modulation. So I'm using these in almost all of my patients, and I think we're going to see the advent of things like that, and the SGLT inhibitors like Jardiance, which is another basically diabetes drug that we're finding has all these other immune benefits. I think we're going to find some of these drugs probably start surpassing uh, rapamycin in the longevity world.
Yeah, I think it's really, again, this is why these conversations are so important, just to kind of expose listeners to different perspectives. And I think GLP-1s have just taken such a hit because
I
they're being
know.
used
And it's too bad.
inappropriately, not judiciously. And yet I actually said to a previous guest earlier, I really think that at some point there will be a clinical indication at micro doses or at these personalized doses for just about every person, not in a way that people are dependent or people are using it because
Right.
they're dealing with latent eating disorders. I've even heard about that. I had a nurse practitioner colleague who said, I lost 40 pounds. I'm going to take this till the day I die because it's the only thing that's helped me like turn the food noise off. And so I think for a lot of individuals, it's just understanding that there's different ways that we can utilize these
Right.
drugs
Utilize these drugs. Right. Instead
efficaciously.
of, right. Right. I mean, even probably the scariest study that came out recently was the blindness study. And I deep dived that because, of course, all my patients came to me like, oh my God, this is horrible. Because obviously that's the biggest fear, you wake up blind, right? But, and that study had at least a little bit of validity to, but all the people were brittle diabetics, not
Mhm.
all big weight loss jumps, but all of them had a very big rapid drop in blood sugar, which can cause retinopathies and other problems. So,
Mhm.
in the normal person who is healthy that we're using these for its protective benefits, those are not risks that we're going to see. And I think that to scare people away from these drugs, unfortunately, because of all the bad press, from being used inappropriately or for different reasons, is is a disservice to us.
Well, and I mean, look at, we know that negative information is kind of what feeds the machine of social
Yeah,
media
right,
or
right.
the news. And so if it bleeds, it leads, as they sometimes will say. So anything that's fear mongering is going
Right,
to,
of course. Right.
resonate for
It's gonna
sure.
sell. It's gonna sell more to read. This drug causes blindness, versus this drug is gonna be protective of your immune system.
Yes. Well, they're like, oh, that's not sexy because I don't even
Right.
understand what the immune system is. And maybe
Exactly.
this is a good segue into other types of peptides that you are utilizing with middle-aged patients. I mean, the options obviously are endless, but what are some of your favorites that you like to utilize with your middle-aged female patients?
Well, let's keep on that immune health because if you think about the other big reason our immune system takes a hit, it's because we have this giant gland we're born called the thymus gland, huge gland in your chest. If you do an X-ray of a baby, they have this huge mass in their chest. That's the thymus gland. The thymus gland is actually sort of training your lymphocytes to go out there and fight that disease, not you. So they're training self versus non-self. And about puberty, which is why puberty probably your best immune system, it starts shrinking. I'm in my 60s. By the time you're my age, it's just a fatty nub. So what does the thymus gland do? Well, it makes what we call thymic peptides. And thymic peptides are at the base of immune health and or at the root of immune health and healing and recovery. So there's two main ones that we really like. One is called thymosin alpha 1. Thymosin alpha 1 is the big immune modulating agent. And again, we make a ton of it when we're young. We don't make it anymore, or very little of it, because we don't have a functioning thymus gland to make it. In France, they try eating sweetbreads, right? They try eating thymus gland, but we can't really eat it and get the benefits. But this, you guys who think, oh, peptides. And do all your listeners know what peptides are, Cynthia? So basically, Zadaxin is actually a drug. It's widely used in Asia. It's used in other countries. It's an approved drug for helping with cancer patients, for helping with immune patients with vaccine intolerance. They give it. They give it. They help with viral, using it for hepatitis. So basically, this is a drug in other countries, not available here, sadly. It's just, going through the whole FDA process just takes such a long time. I mean, because it takes 17 years to get a drug through the profile to actually get FDA approved. And some of these companies don't have the money to do it. So Zadaxin has made a huge impact in other countries, especially Asia, India, and you can go there and get it, very easily. But here it has to be compounded. It's hard to find, but it is the number one sort of stimulus of getting the immune system healthy. If I have somebody who truly has a severe autoimmune disease, it's going to be my go-to, and at a relatively high dose. You can't really even overdose on thymosin alpha 1. You could take it IV, at high doses, and it wouldn't bother you. And then the other peptide the thymus gland makes is called thymosin beta 4. A lot of your listeners have heard of TB500. TB500 is really a fragment of TB of thymosin beta 4. It's not really the right drug. It was got that name from some horses that was used on, but it's thymosin beta 4 is actually the full peptide, and that's what you really want. And it's, again, that's another big piece of our thymus gland. And what thymosin beta 4 does is it initiates healing response. So for if you have wounds, if you have an injury, if you have a brain trauma, thymosin beta 4 really comes into play for growth, healing, getting new blood vessels in. Thymosin beta 4 is one of those peptides that I use a lot for healing, and I'll cycle it in and out for people because it does, like, my sort of my rule for treating people for longevity is, let's replace the things that we've lost. We've lost all our hormones. Let's replace those. We've lost our thymic peptides. Let's replace those. So I'll cycle people through the thymic peptides at least a few times, 3, 4 times a year, because I feel like, okay, I'm going to keep them when they were at their healthiest, sort of at puberty levels. But you have to be careful because thymosin beta 4, anything that causes a lot of growth and new blood vessel formation, right? If you keep doing that constantly, could you encourage cancer cell growth? Maybe. We don't know, but possibly. So always with the mind of safety in the background, we cycle thymosin beta 4. We don't do it for long periods of time, where you could do thymosin alpha 1, particularly if you had an autoimmune disease, ongoing forever and wouldn't hurt you. So those are sort of the big peptides I go to because those are the ones that are so critical to healing. So let's look at other peptides that drop as we age, right? So when we think about peptides, we think about there's some foreign thing out there that somebody made us and we took, like a medication. But many, not all, but many of the peptides we use are endogenous, meaning your body makes them, like these thymic peptides. So what other peptide does our body make that basically is dropping as we age? Well, the main one there is going to be our IGF. Now, my IGF, or insulin-like growth factor, comes from growth hormone. So our pituitary basically stimulates growth hormone production. Growth hormone tells the liver to make insulin-like growth factor. Insulin-like growth factor goes everywhere to help heal, to help your brain, to help your immune system. So IGF is another thing that really drops that as we age. So IGF is basically a peptide, and we can stimulate it. You can use growth hormone, but the hard thing about growth hormone is that dosing it so it doesn't get side effects can be really difficult. The other problem with growth hormone is that it will cause sort of uncontrolled growth of certain things, particularly your organs. So if you guys remember the old bodybuilders, they kind of those really protruding guts. They had like muscle on the outside, look like six pack, but they would stick way out. That's because they would take growth hormone, and so it wasn't that they were fat. Their liver and spleen had enlarged to the point where their bellies stuck out like this. It was covered with muscle, but the bellies would stick out. So we don't really want to use high doses of growth hormone ongoing. So we can use what I call growth hormone secretagogues. We can use just peptides that basically tell my pituitary, make more growth hormone. It will keep it at a physiologic level. I make more IGF. Higher levels of IGF are shown to be preventative of neurodegeneration, preventative of neurodecline, preventative of muscle sarcopenia, so muscle loss, preventative of osteoarthritis. So that's something that, too, that is probably something that most people should, as they age, consider being on, at least cycling on and off. You can use them continuously. You just have to sort of take 2 days off a week. So you can do a 5-day on, 2-day off cycle, or you could do a 3-month cycle, a month off. Lots of ways to do these. But it's a very safe way to get IGF levels up. IGF has a sweet spot. Like, you can measure IGF. Super high as we get older might not be conducive to longevity. Super low is certainly not. So there's somewhere kind of a happy medium in between that seems to be the best for longevity and preventing decline of my health. So, and then the other peptide our body makes a lot of when we're young and not much of as we get older, especially, you know a lot about gut. This is a peptide that comes from our gut. It's called body protective compound, or BPC 157. It's actually a gastric peptide. So our gut makes it. So if you think about, our gut is always getting injured by things. There's lots of things. You eat something bad, you get a bacteria, something injured. So BPC is there as a protective. Basically, it helps heal the lining of the gut so these bacteria can't invade. It basically helps us recover, but it then can circulate out of the gut to other places in the body to do the same thing. So if I hurt myself, BPC is like, oh, I'm going to head there and help her fix her shoulder. I'm going to head there and help the brain. So basically, I think, and again, BPC levels, you monitor them over time, they drop, especially around menopause in both men and women. They'll drop. So give back BPC now and then, right? Let's give back those things that we know are contributing to our health falling apart. And orally, it's great for the gut. orally, so good for the gut. To really get other effects, it's better injectable. It still has effect orally, so you can buy it really as a supplement orally. You don't even need a prescription for it. You can buy it as a supplement. But injectable does a little bit better for joints, muscles, brain. BPC, like there's some great studies with mice where they took mice and they dropped a little weight on its head. And if the mouse was on BPC, it came out unscathed. If it was not on BPC, they had significant brain trauma and they couldn't do their little maze afterwards. So we know that BPC is really neuroprotective. So I love like my athletes, you've got kids who are playing football or something like that. Have them do a little BPC just, before they play, and they're going to be protected in case they get hit in the head. We need to always be thinking this, how do we protect ourselves from the long-term damage? So I think those, those are kind of the mainstay is the thymic peptides, the growth hormone secretagogues, and BPC. And then if you want to get a little more fancy, the last thing that really starts to decline in us is our mitochondrial function, which is why you watch like your 5-year-old running all over the place. And you're like, oh my God, how do they have that much energy? It's because they have a ton of really healthy, active mitochondria, and we don't. So mitochondria produce their own peptides, and there's a few of them. There's MIDA-C, there's SS31, there's humanin. They all have a little bit different purposes. As we age and we have less mitochondria, we have less of these mitochondrial peptides. And really, we always, you learned in school the nucleus was in control of the cell. It's not. It's the mitochondria. So the mitochondria sends out these messages to the nucleus. Hey, do more of this, do less of this, and so that's kind of the control center. And if we don't have as much of these things being produced, I'm not going to have such normal metabolic function. So we can use things like MIDA-C to sort of stimulate mitochondrial function. SS31 is a reparative peptide. We use that a lot in our post-COVID people. So these peptides can be used now to regenerate my mitochondria. And again, if I preemptively, even if I'm feeling great, right? If I preemptively know these are dropping, what if I just do it a couple of times a year, right? Then I'm going to be a whole lot better off when I'm 80.
I think this is such a fascinating conversation because I feel like peptides are like the icing on the cake when you already have someone that's kind of dialed in on lifestyle and then you're adding in, hormones and then, the next layer of functionality. And when we were talking before we started recording, you said, I think a lot of people are jumping automatically to a peptide when there's all this foundational work that still needs to be done.
Right.
To your point about the thymic peptides and then looking at these growth hormone secretagogues, obviously there's different types of growth hormone secretagogues. And I think a lot of women that listen to this podcast will say to me, I lift weights, I eat enough protein, I get good sleep, I'm on HRT. I'm struggling to build muscle.
Mm-hmm.
And so I start to think about not only am I starting to consider that this might be the next thing for me to layer in, but I'm sure you have a kind of methodology because there's different types of growth hormone secretagogues. When you're looking at your middle-aged patients, whether it's tesmorelin or CJC, some of these other peptides, how do you go about making a decision as to which is a better choice for the individual? If we're looking at the average middle-aged menopausal female.
So some of it's what their goals are, and some of it is what their levels of IGF are. So I base a lot of things off lab work, right? So if I see somebody who comes in, and we see this a lot where everything's optimized, everything should be great, and then you get an IGF level and it's 50. We want this thing 190. We don't want it 50. So, when you see an IGF level 50, I probably am not going to get there with CJC and ipamorelin. So usually there's two kinds of growth hormone secretagogues. There's growth hormone releasing hormone and growth hormone releasing peptides. They work best synergistically. So growth hormone releasing hormones are like CJC and tesmorelin. And then growth hormone releasing peptide is ipamorelin. The growth hormone releasing hormones tell my pituitary, make a little more growth hormone. The growth hormone releasing peptides are like stepping on the gas. So one fills the gas tank, one steps on the gas. So if you use them synergistically, you get a lot better effects than either one independently. So usually I'll use CJC with ipamorelin or tesmorelin with ipamorelin. So growth hormone releasing hormone with a growth hormone releasing peptide. And that's by far your best effect. But tesmorelin is much stronger than CJC. And so if I have somebody who's really low, who I really need to bring up, usually I'll head to tesmorelin. Or tesmorelin is really good for visceral fat. It's actually an FDA approved drug. It's called Agrifta. So if, those of you who are scared of not being FDA, this is an FDA approved drug used for what we call lipodystrophy. The HIV patients, the drugs they get on makes them accumulate visceral fat, and so this drug's utilized to counteract that effect. So it has an approval for getting rid of visceral fat. So if I see somebody who has a big old gut, a lot of visceral fat, fatty liver disease, I'll
Mhm.
go to testosterone because it's more documented to have an effect there. For most of us, for a lot of us, the testosterone is just like if I take it, I get bad side effects. It's strong, and I'll get edema. I'll start to get carpal tunnel symptoms, almost like what growth hormone might do. So for me, it's just a little too strong. Even at a low dose, I don't do well on. So you have to kind of find that some women, particularly men, seem to like testosterone better. For some women, testosterone just might be pushing that IGF a little bit too much or surging it a little bit too much. In which case, CJC is just a little more physiologic. Again, am I going to get the IGF from 50 to 190 with the CJC? Probably not, but sometimes you do. So I'll oftentimes start there and then work my way up. Uh, CJC is a little less expensive than testosterone too, so oftentimes it's just the easier choice to kind of use on people ongoing. So I just, I do CJC and ipamorelin ongoing 5 out of 7 days. The hard thing about the growth hormone secretagogues is you do have to take them on an empty stomach, so you have to, find the right time. The best time is either before you go to bed because that's when our growth hormone naturally surges up. But if you really want muscle building effects, it's really nice to do them right after a workout. So then you have that problem. Okay, well, I want to take them right after I work out, but I want to get my protein loading in. How do you time that? So I actually have it in my car. When I'm home from the gym, I take some, and then when I get home, get ready, and then I have my protein. So it's usually my protein's within 2 hours still. So that's the tricky thing about some of these things. But nighttime is great because it will help with sleep when
That
you
was
get that
always, but my
crossover surge
question
at
was,
night.
I bet you improves, deep sleep
It
metrics.
improves deep sleep quite dramatically. It helps with recovery. So people, so that's probably the more common kind of time to take it. If I have somebody who really wants to work on muscle building, lots of times I'll have it even twice a day, post workout and before they go to bed.
Yeah, I
But
mean,
they really are so valuable. I mean, you're exactly right. If you're not putting on muscle and you're on all these things, and vice versa. I had a guy he was huge. He had huge muscles, and he's like, I'm pretty sure my testosterone's low. And I looked at him like, there's no way your testosterone's low. I mean, he was giant. And sure enough, his testosterone was low, but his growth hormone, his IGF, was sky high. So it was protecting his muscle growth, even in the face of this low testosterone. So IGF plays a really big role in muscle growth.
I think this is important because we get a lot of questions, and certainly this is not my area of expertise. I mean, I know a little bit, enough to facilitate a conversation, but how many women I talk to that are like, I'm doing all the right things and I'm lifting heavy enough and I'm
Right.
eating the protein and it's like a job and I'm
Yeah.
just not
Not putting on
building
muscle.
muscle.
And
In
then so
fact,
that's,
every,
I would encourage all those people to go check an IGF level. If you've
yeah,
got an IGF
well,
level that's less than 100, it's going to be much harder to put on muscle.
yeah, and I think, we talk a lot about body composition testing and why that's so important. And the one thing I always get from those readings is you need to put on 5 pounds of muscle. I'm like,
Muscle.
dude, I am trying. It's like a
You're
second
right, right.
job.
I
So
know. Trying to
I,
eat
I, I
150
think,
grams of protein and feel like, it's like so hard.
yes, exactly. And why very transparently, I'm known for intermittent fasting, but it's not something I do regularly anymore because in order to get all that protein in,
Protein in.
I
Right.
have to have like
Yeah,
a,
I'm
a
in the same boat
12-hour
as you.
feeding window.
I can't keep my protein stores up. And I'm like you, I'm thin. I have a harder time putting on muscle. And so I feel like every time I would do like a fast, it would unfortunately be detrimental. And I'd be like, okay, now I'm down and now I'm up. It's like, so I went to, I still make sure I have 12 hours between eating, but I got rid of the longer fast for me because I was finding I was not good for me. I needed the protein too much.
Yeah, and I think a lot of women are certainly kind of figuring that out. As we're navigating this conversation, it always comes back to estradiol, progesterone, testosterone, and then considering anabolics because again, a lot of questions came in about anabolics. Where does that fit into the milieu or conversation when you're working with your perimenopause and menopause females? Because I do know that there are women just very transparently that have shared that they're taking anabolics and they're using them very conservatively with a really excellent physician provider. But how do we know how these all fit together when you're making clinical decisions about your patients in particular?
I I definitely prescribe anabolics, and I'll tell you why for a couple of reasons. For those guys, so anabolics are going to be, your sort of hardcore steroids. These things like nandrolone or oxandrolone, sort of big in the bodybuilding world. I lecture at Olympia. I know the bodybuilding world. I work with bodybuilders. So, so these are pretty commonplace, right? To really get that bodybuilder look is hard to do without anabolics. So obviously you don't want to go overboard on anabolics or you'll look like some of those you've seen them, they look like guys. I see them at Olympia all the time. You're like, wow, yeah, there's nothing girlish about that person anymore. So you can't go heavy on the anabolics, but at a conservative dose they are super helpful for building lean muscle and bone. One of the main places we use them for in our practice is our osteoporotic or osteopenic people because they are very anabolic to bone, muscle and bone. So you can actually put on significant amount of bone on some of these little frail people who, don't want to go on a stupid bisphosphonate drug that's going to create bad bone. This creates nice, good, strong bone along with muscle. And then you can dose it at a dose where you will see some, good advantages from your workouts. You have to still work out. If you don't lift weights, nothing will happen. But you can definitely see more advantage. And again, you don't use them for like 6, 8 weeks at a time. Take time off, cycle on and off of them. Use a conservative dose that gets you to where you want to be. So I use nandrolone more than oxandrolone, partly because it has more medical literature to support it. There's studies that show it for post-op recovery, studies that show, I mean, it actually was a go-to drug for a long time for low bone density. It just kind of got abandoned as we came up with some of these pharmaceuticals, but it really was the go-to drug. And if you look at it from recovery from surgery too, people recover much faster, like from a joint replacement or a rotator cuff repair or things like that, if they take a little anabolic along with. So we use it a lot in our practice. My background's orthopedics, so we use it a lot in our healing and recovery of our patients. I use it a lot in my women who are sarcopenic that just have poor muscle mass. And I think that yes, you don't want to be overusing these things, but to kind of be absolutely terrified of them, and then you read about them, like all these horrible things. They're actually very safe used appropriately and can have a lot of advantages. So I think again, much like our GLPs, right? Those scare tactics scare us away from these things when they can be so helpful for treating some of these disorders in a much safer fashion. To treat nandrolone for bone density than to put something on a bisphosphonate, which we know has, you get increased risk of fractures and jaw resorption, all these bad things.
Well, and I think because of your background in particular, because you were an orthopedic surgeon for such a long period of time, I would imagine some of these, the utilization of some of these drugs very targetedly, conservatively can yield really incredible results. Because how many women write into the podcast and they're like, I'm osteoporotic, I'm
Yeah,
osteopenic, I don't want to take the biphosphates. We know there's a lot of side effects. I'm not telling anyone listening to stop their medications. I'm
right,
just
right.
saying we know that they don't necessarily build and lay down good, healthy bone. And
Exactly.
so understanding that there are other options that are out there, I think that's quite significant because I think,
It's huge because women don't, and doctors don't know anything about it, right? The
no.
doctors don't know anything about using, these other things that you can utilize. Again, hormones still forefront of that osteopenia. But, and those of you guys who have not had bone density studies, really, I encourage everybody, probably starting in your 40s now, because we're seeing low bone density so
Mhm.
early in women, partly because, you know, like your generation, my generation, the super skinny, nobody ate,
Thin is in.
the low
Mhm.
fat diets, that unfortunately most of your healthy bone formation occurs up until about 25, and then you actually start to lose it. So any of you guys who were really skinny, I was, super skinny in high school and didn't eat, you're on that whole bandwagon of, just skinnier is better. That's a bad thing for your bones. I really encourage if you guys have not, I don't see doctors ordering DEXA scans enough. You really need to take that in your hands and know if your bone density is low because fractures kill people.
Yeah, I think a lot of people don't realize that, when someone falls and breaks their wrist or breaks their hip or hits their head and, those kind of frailty indicators are things that if you don't get ahead of it, it becomes problematic because you actually will lose strength before you lose muscle. And that's the physiology. Like I jokingly say I'm the only female in my house and I never let anyone open anything for me. I'm like, if it's a jar, anything, I'm like I have to be able to do it myself. It is very important. We don't want to lose strength in terms of supplements or ergogenic aids that you are excited about or you use regularly with your patients? Do you have specific things that you really enjoy? I know from other podcasts, I know some of your preferences, but I'm curious, what are things that you're using with some regularity with your patients that you enjoy and think that, they can be multi-purpose? That's the things that I like to use.
Well, obviously, there's the basics everybody needs, right? You need D3 with K2. Everybody needs magnesium. Everybody needs a good B complex. Those will sort of take as the given of these are just the baseline that everybody needs. But we are getting more and more recognition, both for muscle and brain health of creatine.
Yep.
So creatine has so many benefits. Everybody needs 5 grams of creatine. If you're taking the concrete version, which is liposomal, you can use less. But everybody needs at least 5 grams of creatine. If you're working out hard, you may need up to 10 grams. I add a scoop of it to my water while I'm working out in the morning. I have another scoop during the day that I'm drinking. So I think that is absolutely critical. It's a no-brainer at this point. The studies are so huge. And like for methylation too, we forget that we need this for methylation. We have to have creatine, and if we don't have enough, that we actually can't methylate well. So some people have these high homocysteine levels, and they're like, "Well, I'm taking all my B vitamins, I'm doing everything." If you have to add creatine on board too. And so that's one I think gets forgotten. The other big thing, and this is not really a supplement as much as it is food. You can take it as a supplement, but the supplement's not as good as food, and that's choline. So we now know the cell membrane for all of our myelin, we need phosphatidylcholine. A problem with plant-based, if you buy phosphatidylcholine as a supplement, it comes from sunflower lecithin. It's plant-based. That doesn't actually have the ability to cross the blood-brain barrier and help the brain and really help myelination. So really the best way, I tell everybody, you need at least 2 to 3 eggs a day. So
Yep.
that's the best way to get, choline a good amount. Everybody needs 2 to 3 eggs a day. I don't have time to breakfast. A lot of times it's my dinner. So, it's an easy thing to make for dinner. Make some scrambled eggs for dinner. Um, if you still have young kids at home, it never goes over well. But now my kids are all so so make sure you're getting enough choline. I think one of the things I'm really am looking at a lot now is alpha ketoglutarate. And the hard thing about alpha ketoglutarate is that it's very short-lived in our system. So you want probably like what's called a calcium alpha ketoglutarate. But we're now, in fact, I just saw a study that just came out on alpha ketoglutarate and dementia. I think it came out like yesterday. But alpha ketoglutarate, we know is a critical player in mitochondrial health. It actually feeds into the Krebs cycle at a different point so we can make more energy. So really more energy, more muscle, more brain function. And so I think alpha ketoglutarate needs to be moved up is something people need to be looking at more. I think we're going to see more and more stuff coming out about it. The biggest trick is that it isn't long lived in the system, so you probably need to take it a couple of times a day, even the calcium alpha ketoglutarate form. I'm talking to a company who tells me they have a much longer acting form. We'll see. But that's one I want to kind of put high up on the list too. And then, again, depending on your age, something a lot of people don't know about is plasmalogens. So plasmalogens are a specialized phospholipid. We talk a lot about the phospholipids. Phospholipids are so critical, right? It's why you don't want your cholesterol to get too low. Phospholipids make up your myelin, your cell membrane. They're sort of responsible for everything that's getting in and out of your cell. And so choline is a critical player there, but so are the plasmalogens. The plasmalogens actually coat all your cells. They have to, and your myelin. They act as this kind of protective coating. And you can't really eat them. So you're sort of what you're born with or how much your peroxisomes make is what you've got. So basically, as they drop, we know that we start to see, more numbness and tingling and energy and fatigue and brain. And there's some Dr. Dan Goodnow, who studied the most about plasmalogens, has shown that people who have high levels of plasmalogens do not develop dementia. He's been studying people since 2006, even people with the ApoE4 genotype. So these are absolutely probably going to be a critical player, especially if you're over the age of 45. The problem is, again, there's not any supplement you can take, but he made what's called a plasmalogen precursor that can cross the blood-brain barrier and become plasmalogens in your brain. So I actually think those are something people don't know about that people need to investigate and understand more. It's a whole conversation about them because they can do so much for both protection, but also to help inflammatory things, autoimmune diseases, great for heart, great for brain, great for eyesight. So I think plasmalogens need to be kind of something people are more aware of too. I'm trying to think of things that like people haven't really thought of that I have in my regimen that I think are pretty critical. Because you hear so much about sort of the basics, but I think those are some of the pretty critical ones.
No, and I mean, two of these are new. So for me, I'm glad I eat eggs every day, not a
Yeah,
problem. Creatine, checkbox. The other two, not as
yeah,
familiarized
and I
with.
think we're just
Definitely.
kind of really getting aware. It's funny when I was doing a talk recently on long COVID and looking at where alpha ketoglutarate could really come in and be a huge player just because this whole cycle, the Krebs cycle, where it feeds in, it saves a whole lot of energy. You can make a lot more energy with less energy expended. So it's actually really an interesting player. And again, I think we start seeing more and more data on it. That, and again, the plasmalogens you need to look into, especially over the age of 50, especially if you know anybody who's an ApoE4, either one ApoE4 or two, they need lots of plasmalogens
Yeah.
protected.
Well, and I think it's one of those things where I think the older I get, the more conscientious I am about brain health in general,
Right.
especially in talking to most of my colleagues. I think everyone's greatest fear is that they're going to
Yeah,
have some
dementia.
neurocognitive deficits. So,
Yeah.
doing all the things to help protect our brain
Because it's
health.
so horrible, right? It's like, and I think the brain gets a little neglected. We're getting more aware of it now, but it gets a little neglected, and we're seeing a tsunami of neurodegenerative diseases, Parkinson's, ALS, Alzheimer's. COVID, the spike protein appears to be a big player here. It seems to cause a lot of brain stuff, but the world this is getting worse and worse and worse, and so we really have to get into. I think our focus needs to be, yeah, let's all look good and have great muscles, and but we've got to start focusing a little bit more on brain health.
Yeah. And I think that there are so many things we can do proactively. It doesn't have to turn into this doom and gloom, like this just
Right.
happens to me.
Right.
I feel like in a lot of ways, I just got back from kind of a wellness retreat that I went to, and they were doing all sorts of brain testing and body composition testing. And I was joking and saying to them, you had me doing memory testing on a day where I got 3 hours of sleep. I was like, probably better to test me on a day when I've gotten a little bit more sleep. And so they retested me and I was fine. But the point is, we definitely want to be doing things that are helping preserve neuroplasticity, are helping to improve, brain health, brain metrics, and not being afraid to learn new things, which I think is so important
Yeah.
as we get
And then
older.
exercising our brains, right? We forget that too, that you need to be, reading new things, learning new things, playing games, playing on online games,
Pickleball.
things that, right, that, yeah, like things that work your reflexes too, right? Those lights that light up and you have to hit one light, at certain color. Those are actually really important. We go and exercise our bodies, but we don't really exercise our brains, especially, once people have left the workforce, right? And they're not getting that stimulation every day. And they're like, well, I'm retired, I'm just traveling around. Your brain starts to go.
Yeah. Well, it's interesting. My mother-in-law is 81 and God bless her, she still does Sudoku like every day.
Yeah,
And
my dad did CrossFit, in his 90s, crossword puzzle every single day.
yeah, takes great pride in that. I would love to invite you back. I would actually love to unpack cardiovascular risk protection and heart health because that is such a huge issue for women. Number one cause of
Yeah.
death, 1 in 3 women. And certainly, the role of like nitric oxide, endothelial dysfunction, the loss of estrogen, and how that impacts our risks of developing cardiovascular disease. If you're open to it.
Yeah, I'd love to talk about that. And then some of the new screening tools we're using too to sort of figure it out. Because, you guys who are getting your coronary calcium score and it's zero, it means nothing. So we have to sort of educate people around what are we looking at? What are we looking at when we're looking at lipid numbers? What is a healthy lipid profile? So I think it's a fascinating conversation. There's, again, the cardiac world, there's so many things you could do too, including the GLP-1s.
Absolutely. Well, Dr. Yurth, this has been an incredible conversation. Like I said, I'm hoping we can do a round two diving into heart health because I think we just can't do enough to help patients understand what their real risks are and what they need to be
Right.
doing beyond kind of traditional lipid panels, which are largely garbage.
Right.
Hey, if you like this video, you guys are going to love this video, and I'll see you there.
If you have either uncontrolled diabetes, and this goes for type 1, type 2, LADA, MODY, any form of diabetes, if you follow the standard, if you follow no advice, you're probably going to hasten your death even more than 3.5 years for each decade you have it. But if you follow the standard advice, the state-of-the-art advice, the scientific consensus advice, then yeah, you're probably going to be knocking 3.5 years off your life for every decade that you follow the American Diabetes Association recommendations.